Aren't you lucky? You just heard this hot off the press, because these guidelines, this group has been working for over a year. It was a very different experience for me than working with the dietitians or nutrition management guidelines, working with very experienced clinicians, and the results of the Delphi and the variation in practice, despite having this disorder on the newborn screening for years. So hopefully we'll get those out soon. So our next speaker, it's with great pleasure I introduce our next speaker, who's a friend and a colleague. We trained together at Emory many, many years together, under Dr. Skip Elsis, who actually started the SERGG meetings. Dr. Pasquali is now a professor of pathology and an adjunct professor in pediatrics at the University of Utah School of Medicine. She's also the medical director of biochemical genetics and newborn screening and section chief of biochemical genetics at the ARUP Laboratories in Salt Lake City. Today, she will give a presentation on newborn screening of GAMT deficiency, the Utah experience. This is a very timely topic because at the Secretary's Advisory Committee, this disorder is top on the list by the family advocates to be nominated, and it really lost by one vote, literally, not to get on the screen. So it's getting close to it, so it's very timely. I very much appreciate Dr. Pasquali taking time from her busy schedule to come join us.
Thank you, Ronnie, and thank you, the organizer, for, if I can get this. And thank you for inviting me to this meeting. And actually, this meeting has been probably one of the first, if not the first meeting I attended once I moved from Italy to the United States, and we're going back to 1986, so quite some time. So I am going to discuss guanidinoacetate methyltransferase deficiency. I have no financial disclosure related to this activity. I will talk about creatine and its function, creatine deficiency syndromes, especially focusing on GAMT deficiency, the newborn screening for it, and our experience, preliminary results from our experience. So creatine is a nitrogen-containing organic chemical that supply energy to the muscle. To the muscle and nerve cells, and was identified as a component of skeletal muscle, and it was named creatine from the Greek word kreas, which means flesh, meat. So the creatine is a shuttle of energy between the sites where energy is produced in the mitochondria and the cytosolic sites where energy is needed. And again, carries the energy as phosphocreatine. The creatine derives, 50% of the creatine derives from the diet, and the rest is synthesized. And it's synthesized using two enzymes, AGAT, arginine-glycine amidinotransferase, and GAMT, guanidinoacetate methyltransferase. Once it is synthesized, there are specific transporters that allow creatine to reach all the organs, including muscle and brain. So if we look more closely at the biosynthesis of creatine, it starts from arginine and glycine. The first enzyme involved in the synthesis is arginine-glycine amidinotransferase, as I mentioned earlier, or AGAT, and this enzyme converts arginine and glycine in guanidinoacetate and ornithine. and then guanidinoacetate methyltransferase and with S-adenosylmethionine converts this guanidinoacetate in creatine. And then again, we have the transporters that allow the creatine to reach all the organ. Defects in either the synthesis of creatine, so deficiency in the 2-enzyme precursor of creatine, or deficiency or defects in the transporter of creatine result in brain creatine deficiency, which are characterized by neurological symptoms and mental retardation, autistic features, and disturbance in speech and cognitive function. They can also present as with moderate mental retardation, attention deficit, and hyperactivity. Initially, these disorders were diagnosed because by measuring the creatine in the brain using MR spectroscopy. And now, of course, we have other biochemical tests in addition to the MR spectroscopy, and most importantly, as I hope I can convince you, we have newborn screening that can detect at least a GAMT deficiency. GAMT deficiency is an autosomal recessive disorder which is due to impairment in the guanidinoacetate methyltransferase, and which is again the second enzyme involved in the synthesis of creatine. The incidence is now well known in our state in Utah based on the clinical ascertainment over the last few years. We have estimated the frequency to be, the incidence to be 1 in 120,000. Presentation, as I mentioned before, includes developmental delays, hypotonia, seizures, and autistic-like behavior. Diagnosis, again, lack of creatine peak in MR spectroscopy. There are specific biochemical findings in plasma and urine when measuring guanidinoacetate and creatine. Specifically, in patient diagnosis, we see an increased plasma guanidinoacetate and low creatine. There is a therapy, and the therapy consists in administration of creatine, and of course, the outcome is excellent if the therapy is initiated very early on, before there is a brain damage. And in addition to creatine, guanidinoacetate levels need to be reduced, and this can be done by ornithine supplementation and benzoate. So this is one of the patients who's followed at the metabolic clinic at the University of Utah. She was diagnosed probably around 2 years of age. She had already a delayed development at 6 months of age and developed seizures by the age of 2. And there are 2 MR spectroscopy example. This is a normal control, and what you are seeing in these traces here is the biggest peak that you see is due to N-acetyl aspartate, then choline, and then there is this peak of creatine, and this is a normal MR spectroscopy. In our patient, we still have the N-acetyl aspartic acid, the choline, but the creatine peak is missing. In addition, I've mentioned the biochemical test for diagnosis creatine deficiency syndrome, and they consist in measurement of guanidinoacetate in plasma and in urine, guanidinoacetate and creatine. And in patients with AGAT deficiency, which is the first enzyme in the creatine biosynthesis, we have low creatine and low guanidinoacetate. Again, this is the enzyme that converts arginine and glycine into guanidinoacetate. And in GAMT deficiency, creatine is low, guanidinoacetate is high. If we want to look at the transporter defects in the creatine transporter, plasma creatine and guanidinoacetate will be normal. In the urine, the ratio creatine-creatinine instead is going to be very high. So a combination of plasma and urine, guanidinoacetate and creatine can really guide the diagnosis and help in the diagnosis of creatine deficiency syndrome. Then the diagnosis is confirmed by enzyme or transporter assay and or DNA testing. And nowadays, DNA testing is the first choice for confirming a biochemical finding. So, oh, sorry. Wait. Okay. These are the results of a couple of our patients when we looked at the creatine and guanidinoacetate in the plasma. As you can see, the level of creatine are markedly reduced compared to the normal value, and the guanidinoacetate instead are markedly elevated. And so this pattern is consistent with GAMT deficiency. The treatment, once again, is to restore creatine and reduce guanidinoacetate. And if we look at the brain MR spectroscopy before and after the therapy, so this is MR spectroscopy on your left. You have the MR spectroscopy of one of our patients at diagnosis, where you can see creatine is missing and GAA is guanidinoacetate is fairly high. And on your right is after the treatment, and there is creatine now is present, and guanidinoacetate is reduced. So again, to be more specific in the treatment, creatine, again, should be initiated early in life. And because guanidinoacetate can be toxic and can be, we need to reduce the level, and by supplementing with ornithine and reducing glycine with the use of benzoate. The outcome is excellent if it's initiated early, and we have some evidence because we have patients who have been identified because at birth because of their siblings, and they are doing very, very well. So with all of this, clearly we wanted to explore the feasibility of adding GAMT deficiency to the newborn screening. And we had a marker, which is guanidinoacetate, and we started in 2013, actually. We did this pilot project. We used 10,000 de-identified ribose spots were left over from our original screening program, and we added the internal standard for creatine and guanidinoacetate, and we measured them in parallel. So we basically used the same method that we used for our newborn screening and measured guanidinoacetate and creatine. Abnormal results were followed up with a second-tier test using liquid chromatography tandem mass spectrometry. And again, the aims of this study was to evaluate the feasibility of the screening, evaluate the false positive rate, and also evaluate the effectiveness of second-tier testing. There is 10,000 blood spots where half of them were collected at less than 7 days of age, and half were collected greater than 7 days of age. So I don't know if all of you know, Utah is a 2-screen state. We collect the first screen between 24 and 48 hours of age, and the second screen, which is mandatory for all the children, is collected between 7 and 28 days of age. So we wanted to evaluate whether there were any differences in the concentration of these analytes and again, in the detection of this condition. So this is just to give you an idea of the blood spot that we used. In addition to this blood spot, we also had 7 blood spots from 3 patients with GAMT deficiency, and they were collected between 1 and 21 days of age. So we had blood spot, 3 were collected before 7 days of age, and 4 of them were collected after 7 days of age. So we felt that we had a good number also of true positive to validate our method. So we looked first at the distribution of GAA and creatine in the 10,000 dry blood spot, just to see whether there was a difference, whether it was a normal distribution or not. And for guanidino acetate, which is on your left, you can see it's a pretty normal distribution. The 95th percentile was a 1.8 micromole per liter, and the 97.5 percentile was 2.1 micromole per liter. When we looked at the creatine, it was clearly a bimodal distribution, and there was actually, this is reversed. This on your left here, that's fine. The higher value were for the less than 7 days of age, and the lower value were for the greater than 7 days of age. So when we looked at the percentile values for the 2 groups, we had confirmation of what we thought. So for GAA, there was no difference between, let's say, the first and the second screen. And for creatine, instead, there was definitely a big difference between the first and the second screen. So the cutoff for creatine would have to be adjusted according to age. So now here we looked at the values of guanidino acetate in this 10,000 blood spot according to age. And here are the value. The guanidino acetate is here on the top panel. And the mean plus or minus the standard deviation in the 10,000 blood spot are represented by the open circle, and the black square represents the value for the patient with GAMT deficiency, patients who were confirmed with GAMT deficiency. As you can see, there is a pretty good separation between the 2 groups. Instead, for creatine, the creatine level at less than 7 days of age was really overlapping with the, let's call it, normal population. But interestingly, at the time of the second screen, so basically after 7 days of age, in the patient with GAMT deficiency, the creatine was significantly lower than the mean for the normal population. So with all of this in mind, and again, looking at the distribution of the value in our patients, confirmed patients, we decided to look at a cutoff for GAA that was corresponding to the 99th percentile of the normal population, and it was 2.45. And here on the top panel is, again, in this graph, I have divided the values using the cutoff of 2.45 for GAA. Again, the black circle are the normal population, and the open circle represent the GAMT patient. Now, still there are quite a bit of normal that are falling into the abnormal category. So we try to use the ratio GAA creatine to further separate these two groups. And on the bottom graph, you can see that now if we're using a cutoff of 0.01 for the normal population and for the ratio, and 2.45 for the GAA, now we are reducing dramatically the number of positive that we have, and yet including all of the true positive. So all of these, we followed up, as I said, all of the abnormal, and this time everybody with a value of GAA above 2.45 with a second-tier test for GAA and creatine, and this again to validate that the ratio was able to really to be applied and without risking to lose a false positive, to lose true positive. And again, the second-tier test consisted in a very similar method, but now we have a separation using liquid chromatography and tandem mass spectrometry, and we have also a quantitation using calibration, an external calibration curve in addition to the internal standard. This is for the laboratorian in the audience, the profile, a chromatographic profile of the second-tier test. So we had in this 10,000 blood spot, we had 60 samples with a ratio that was with a value of GAA that was greater than 2.44, which was the 99th percentile of our population. We did the second-tier test on all of them, and the only positive on the second-tier test were the samples that were coming from the patient with GAMT deficiency. So there were no false positive identified after the second-tier test. So we decided, we talked with our Department of Health, and in Utah, the newborn screening program includes our laboratory, the University of Utah, and the Department of Health. And we proposed to add GAMT deficiency to our screening following this algorithm, primary screening, abnormal, followed up by the second-tier test, and abnormal on the second-tier test by confirmatory test. We went live in June 1st, 2015, and now 13 months later, we have screened over 56,000 babies. And we have done a lot of second-tier testing, a total of 792 second-tier tests. Most of them were from the babies greater than 7 days of age. And we only had one baby who needed confirmatory testing. And retrospectively, this baby comes from the NICU. was a NICU baby. And these, again, are data fresh from the press. I just compiled the data. When I looked at the level of guanidinoacetate and trying to explain why we have so many from the NICU, if there is a correlation with some of the analyte, the only correlation I could find was the highest GAA values on the second tier test, not necessarily above our cutoff for the second tier test, but are correlated with high level of arginine. So we are going to pursue this kind of analysis to evaluate if we can use even further ratios to avoid false positive. So in conclusion, newborn screening for GAMT deficiency is feasible, can be included in all programs with minimal additional cost. The rate of false positive that we have seen is very low. We see a high number of positive screen in NICU babies. High levels of GAA seem to be associated with higher arginine level. Unfortunately, we have not identified prospectively any true positive at this time. And thank you, and I'll be happy to answer any questions.
So what tissue do you do the enzyme analysis in, and do you know a lab that's offering it for clinical service?
The enzyme for GAMT and AGAT, I don't know if where it is, if there is a lab that offers it. For the creatine transporter, it's done in fibroblast, and I'm not sure currently there is a lab performing that test either, unfortunately.